Awesome. So good evening, everyone. I'm Armida. I'm one of the co-presidents this year with LFC, and we're very excited today to hear from our amazing group of speakers who have been so kind as to share their time with us. Before we begin the event, for those of you who may not be familiar with Learning for Charity, we are a student-run nonprofit organization at the University of Ottawa, and we facilitate low cost, so $12 per hour tutoring for university and high school students, with all the proceeds going to the Children's Hospital of Eastern Ontario. All of our tutors are volunteers who have excelled in the classes they are tutoring, and we also offer a mentorship initiative that pairs students with upper year mentors to help them navigate coming to university and hopefully engages them in a group, in different group events designed to help them through the process. And so that's it on my end. I'm not gonna take more time, and without further ado, I'll just pass it on to the events team.
Good evening, everyone. My name is Reka, and I'm the VP of Events for LFC this year. And with me on the events team, I have our amazing events reps, Abigail, Akia, and Caroline. So I just wanted to thank you guys again for joining us tonight. And I will now pass it over to Akia, who will be introducing our first speaker of the night.
All right, so the first speaker today is Adam. Adam started his career in healthcare as a hospital orderly back in 2006. Before joining CHEO as the Director of Critical Care and Surgical Services, he spent 14 years working his way from orderly to a critical care nurse in the ICU that specialized in trauma, neurology, neurosurgery, and vascular surgery. He continued his education and training to become a care facilitator in ICU to clinical management in various areas of the hospital across many disciplines. One of Adam's most unique challenges to date was coordinating the opening of his second PICU at CHEO during the viral surge back in 2022. All right.
Perfect. Thank you so much, everyone, for having all of us from CHEO and for hosting this amazing event. And as well, thank you for all of what you do and your participation in all of this, and for being here tonight. So I'll start by maybe elaborating a little bit more on my career path, just to give a bit more background as to who I am and where I came from. So as mentioned, I started my career as a hospital orderly, and that was at my third year of nursing school. I wanted to get into the hospital and start to experience work life, and so did that for 2 years. And then upon graduation, started as a critical care nurse in the ICU, as mentioned, at the Civic campus of the Ottawa Hospital. And I think one of the interesting things about healthcare is that the opportunities are just so broad and diverse. And so I started to capitalize on that pretty early on in my career. I got a job with Trillium Gift of Life as an organ donor coordinator. And I also worked with the Run Ottawa organization as one of the medical leads for the Ottawa Race Weekend, which for those of you who are local to Ottawa probably know about it. For those of you who are visiting or in town studying, you'll see it in May. It takes over the city for a weekend, and it's a fun event in the city. But of course, you've got 60,000 participants, and some of them drop on the course. And so you do need to have a big medical team response. And that was some fun coordinating that. And then from there, really enjoyed leadership and getting into some of that work. And so went back and did my MBA at Telfer, which propelled me into the dark side of hospital administration. And I really fell in love with that. So my career in the last 12, 14 years has gone from manager, assistant manager in general surgery, perioperative services, endoscopy, a multi-campus endoscopy program, emergency services. I did some quality improvement and process improvement in the emergency services side at the Ottawa Hospital. And then 3.5 years ago, came over to CHEO as the director of surgery and critical care. And I think one of the things that really brought me to CHEO is that it's more than just a hospital. It's so broad and complex. It's a children's treatment center. It's a school. It delivers home care. We really are ingrained in our community, and we do a tremendous amount of research and innovation as well. And so the other thing that brought me to CHEO and really continues to call on me every day is our vision. And that's to provide the best life for every child and youth in our region. And I have 3 children of my own, and it really just calls on me, right? I think to go into work every day knowing that what you're doing is trying to provide the best life for every child and youth is a pretty powerful motivator. And so, maybe some wisdom to impart when you are looking for a job in the future is, really look at the vision of the organization that you're looking to join, and make sure that it calls you and inspires you. So, what do I do today? As the Director of Critical Care and Surgical Services, I directly supervise 8 managers and well over 600 staff across my portfolio. That includes the pediatric ICU, the neonatal ICU, our critical care transport team, as well as our critical care respiratory therapy group. And on the surgical side, our perioperative services division, which runs 8 operating rooms, 2 procedure rooms, 26 inpatient beds, and the entire central processing department for the hospital. So quite a broad portfolio. Really, really do depend on my amazing management team to do the hard work and organize the care. And of course, the 600 staff in my portfolio who do tremendous work every single day. It truly is inspiring. We do just about 8,000 surgeries a year. That entire portfolio spends about $56 million annually, and truly is a pretty big machine. And so my day, every morning, there's daily kind of check-ins, looking at what happened overnight, where Teams chat explodes, usually between 7 and 8 o'clock in the morning with, the updates from the past 24 hours. What's the day looking like? And so we really get ourselves sorted and organized early. And we do something fun at CHEO. It's called the Daily Brief. It's a daily touch point of the entire leadership team, where we really look across the organization to see what's going on and what are the challenges that we might encounter throughout the day and prepare for that. And then I dive into the rest of my day, which, could be team meetings, monthly one-on-ones with my managers, other direct supervisors, as well as physician leaders across my portfolio. So lots of dialogue, lots of coaching, lots of mentoring, and lots of team building. At the same time, there's tremendous amount of committee work, right? So we have clinical operations committees, emergency management committees, emergency response, supply chain, the list goes on. And as much as I can, I try to get out into the units to talk to staff, to talk to families, and see how things are going at the front line. It's important. It is difficult sometimes with the meeting schedules to get out and about, but that's an important piece. And then, of course, looking at operational metrics, leading change, inspiring the team, all of those things that I really enjoy. And then at the end of the day, it's all about checking in again. What's the night look like? Do we have enough staff? What's the patient flow been like throughout the day? And what are our concerns going into the next 12 hours? And I know that this group does have some interest in research, and so I thought I'd touch a little bit about some of the research pieces in my world. And of course, there is clinical research, which I'm not the expert in, and I think Dr. Hugh McMillan will talk a little bit more about clinical research. What really kind of is in my wheelhouse is called operations research. And so, if you Google that, you'll look at simulation, interesting. There we go. Simulation, really interesting computer modeling. You could get into the world of automated intelligence, machine learning, all of those things. And really, we're at the cutting edge of that and how it applies to healthcare. But truly, some of the questions would be, how many beds do we really need to meet the demand? How much staff do we need to run those beds? How many ORs do I need to run for how many hours a day to keep up with the current demand, our wait list, and the population growth? And what are some of those models, and how do you develop that? Everything really needs to be perfectly orchestrated, from your staffing, your supply chain, your drugs, your gases, and it needs to meet demand for patient care in a really timely way. And so we've done that, off the corner of our desks with spreadsheets and Gantt charts for decades. And what's really exciting is now with automated intelligence and some of the new computerized simulation models, we can actually put a machine to that and really advance how we look at things. So lots of fun stuff. And one of the research pieces I like to get into, haven't quite gotten there yet, is looking at implementation research or leadership research or research of leadership. And just looking at how we implement a new project, how we make changes, and looking at whether it's quality review or research, and how we do those things, and how we could do them better. That's all for me. I'll pass it back to the moderators.
Okay, so if anyone has any questions for Adam, they can either put it in the chat or they can private message any of the LFC members, and we'd be more than happy to read it out for everyone. So if anyone has any questions, or you can also raise your hand or just ask them like using your mic as well. Oh, yeah, you can go ahead and ask your question.
Hello. Yeah, I just had a question about the areas of research that you were mentioning. You're talking about, like, I think innovation, machine learning. I wanted to ask what that meant, or like what that was. I don't know. Yeah, and like some other terms I can't remember right now. Yeah, thank you.
Yeah, of course, of course. So you can imagine, the amount of data in a healthcare visit, the timestamps of when a patient moved from A to B to C, all the different physician notes and nursing notes, the medication administration, all of those different things, vital signs, for example, that are put into a patient chart. That's all data that's there now in our database. And historically, we've looked at, we reviewed it. Sometimes we can study it, but that takes a tremendous amount of manpower and time to really digest all the different data points. And machine learning and using automated intelligence is the concept of taking all of that data. For example, we went live with Epic at CHEO in 2018. So we have 18, 19, 20, 21. My math isn't great despite I need machines. We have 5, 6, 7 years worth of data of all the hospital stays in CHEO's, that CHEO piece. And if we allowed, if we sort out a way to allow an automated intelligence system to kind of mine through that data, it'll find patterns, and it'll recognize things in that data that a human will never see, and it will be able to kind of translate that to predictive models or those sorts of things. And so a lot of this uses, I use the term machine learning, and you guys may have heard of like ChatGPT, those sorts of things, where you ask ChatGPT a question and it goes into the internet and it scours millions of different files on the internet and it comes back with the answer. And so this is a similar type of thought, is can you use our existing data models to then say, what if, right? If I added an extra operating room, what would that do to our wait list? Would that eliminate our wait list? Would I still have one? Would it maybe just be smaller? Or you can ask the question, how many ORs do I need to run to eliminate my wait list? And so these are some of the modeling exercises that we're starting to go through. and certainly excited about for the future. I hope that helps. Yes, I see a thumbs up. Perfect.
Great, thank you. I have a question that was sent to me by private message. So this person is saying that you seem like you were like a patient-based ICU nurse in the past, and now you've transitioned more to like a clinical management position. So what do you miss about your old position, and what do you enjoy more about your current position?
Yeah. You know, one of the interesting things that, well, I definitely miss the bedside care. I think I definitely miss being with patients and families at their hardest moments. That was a difficult part of healthcare, but I think an extremely rewarding part of healthcare. And I do miss that for sure. My wife is an ICU nurse, and so we get to share a little bit about, you know, how's your day, and I hear a little bit about that, and so that brings me back. And I also get to go into the units and talk to staff and talk to patients and families. So I do get my fill in that way. What I love about leadership and being in a director role or manager role or just even a frontline leader is the ability to affect change at a larger level, right? As a frontline provider, I was able to help the patient in front of me. As a manager, you're able to help your entire team provide care for the entire unit. And as a director, I'm now responsible for helping my very broad team care for tens of thousands of patients a year. So I appreciate that part of the role is really being able to affect change at a different level.
Great, thank you so much. Does anyone else have any other questions for Adam? You can put them in the chat or speak them out loud or send them to either of us by private message as well.
I can ask. Oh, never mind. Go ahead.
Sorry about that. So, just as you were talking about the operation research, and I can imagine that it requires a lot of data science, like knowledge in that area. May I ask what part of your background prepared you for this area of research and just aspect of the job?
Yeah. And nothing from my background prepared me for what this is and could be. And so in my master's of business, we did a little bit of data analytics and kind of data mining, a little bit of Excel-based work, or actually it's a lot of Excel-based work. But what I'm talking about is, you know, people that need a computer science degree or advanced degrees in that realm. And that's where we lean on our CHEO Research Institute, who have some of that expertise, as well as look external. I think there's potentially an opportunity to partner with tech companies, new innovative health startups, health tech startups. And so I know our research institute is starting to have some of those conversations about how to develop partnerships with companies who bring that expertise.
Thank you.
And maybe I'll add, you know, I think one of the interesting things and why partnership is so important, and this applies to this example, but it applies to so many aspects, is that you can never know everything, right? And so, and that's okay. There's people all around you, companies all around you, who do know things that you don't, and that's why partnership is so important. Developing those partners, those networks, those links, so that when you don't have the answer or you're not entirely sure even what the next step is, you can reach out. My expertise is hospital operations, and so that's what I would bring to that table, is understanding the hospital data, what it means, what questions I need answered. And then someone else would bring in the technical expertise to help solve that.
Great, thank you. There's a few questions in the chat. So from Matthew, what do you see as the biggest challenge facing the healthcare system in the coming years?
That is a fantastic question. And I would say access is probably our biggest challenge in our current healthcare system, and it will probably continue to be our focus for the next little while. We are growing as a population. Specifically, the pediatric population in our region is growing 9 times faster than the Steve will have to remind me if it's provincial average or the national average, but Ottawa's local population is growing much faster from a pediatric standpoint than elsewhere. And so our demand for care is currently exceeding our capacity to deliver care. And so we are rapidly expanding our services. We are growing phenomenally. We're very happy for some recent investments as well as, phenomenal support from our community, including this wonderful group, to allow us to grow and deliver more care to keep up with the demand. So really, it's all about access, trying to get people in and serviced as quickly as we can.
Great, thank you. I have one more private message question that was sent to me. So this student would like to know if you have any advice to students that are applying to certain positions at CHEO, such as a patient service clerk.
Yeah, I think patient service clerks, I'd expand upon that. I think CHEO has tremendous opportunities, whether it's patient service clerks or there's some volunteer opportunities coming up this summer with the Research Institute. I think they just put some of those on social media. And so, yeah, keep an eye out. I think my advice would be bring your best self, right? I think we're looking for people who are compassionate, committed, who work hard, but are also, showing up for the right reasons. If you're someone who wants to help provide the best life for children and youth, that's what we're looking for. So, bring that to the table, bring that passion forward, and that will certainly help you succeed in getting a job at CHEO. And the other thing I'd say is, if you can get a job at CHEO, there's incredible opportunity. We're a big organization. We're growing every day. And I think we've hired, we've got, I think, 160 new positions in the last 6 months and continue to grow and grow and grow. And so lots of opportunity.
Great, amazing. Thank you so much, Adam. I will now pass it over to Caroline to introduce our next speaker.
Awesome. Thank you so much, Adam. That was fantastic. Next up, I'd like to introduce Tina LePage. Tina has been a nurse for 32 years, 29 of them working at CHEO. She was looking for her nursing niche, working as a casual nurse at CHEO when she had her first shift in the NICU in 1997. She still remembers everything about that first 4-hour shift, including the families. She knew she had found her place. Tina has evolved her career, taking on roles as a preceptor, teaching CPR to parents whose babies are being discharged, and in 2018 joined the neonatal follow-up clinic and helped move that forward during the pandemic. She is a clinical resource nurse, working as a bedside educator to support and mentor new NICU staff. She has worked with residents, nurses, and midwives. She also specializes in inserting PICC lines into NICU's most fragile babies. Tina has always appreciated what it was like to be new and wanted to be welcoming to the new additions and help them succeed. CHEO's NICU is a multidisciplinary team, and she gets to welcome them into the profession. The best part of her job? helping a parent hold their baby for the first time, seeing babies go home, and helping families be families. So I'll pass it over to Tina.
Hello, my name is Tina. I'm a nurse here at CHEO. So I have been here for a very long time. I, like my bio said, I was very lucky to find my niche in the NICU very early on in my career. I'm a diploma nurse, so I got grandfathered in when nursing went to the bachelor's program. So I did, however, go to Ottawa U for two semesters and took the neonatal courses so that I could specialize in NICU nursing when I discovered that this was the place I wanted to spend my career. What brought me to CHEO, I would say, so when I first graduated in 1992, I graduated in a very different era. I actually graduated in a hiring freeze across Ontario. So I hope none of you ever experienced that, and I can tell you right now in healthcare, that is not the case. We are hiring like crazy these days, but I actually graduated and no hospitals were hiring. So I had a couple of years where I worked in home care. And when I worked in home care, I actually had the opportunity to take care of children. So when I started, I believe it was 1993 when I was just new to community nursing. CHEO had a unit here called the TLC unit, and it was a unit of children who had, they were medically fragile. They had feeding tubes, they had tracheostomy tubes for breathing. There was reasons why in those days there wasn't any support for these kids to go home. And so I had the incredible experience in helping them get these children home. And so I came to CHEO through the organization that I was working with in the community, and I was trained by CHEO nurses. And they actually closed that unit here at CHEO because almost all of those patients got to go home and live at home with their families for the first time with home care support from pediatric nurses. So I was very fortunate that I got that bird's eye view right at the beginning of my career to see all these medically fragile kids actually live at home for the first time of their lives. And it actually was great experience for me because when the hiring freeze was lifted in 1995, I got a job at CHEO right away, which was really nice because I was already taking care of CHEO kids at home. So that was very fortunate for me. When I came to CHEO, I worked on medicine for the first 2 years, and I think that was a very good experience. It allowed me to work on my time management skills and work on my basic observation and assessment skills. And 2 years later, had the amazing opportunity to come down and work in the NICU for a couple of hours to help them out one day. And of course, instantly fell in love, and I've never left. So I think if you are incredibly lucky, I give a lot of student tours to Ottawa U students, nursing students here at CHEO, and I always tell them if you are lucky to find the place that you belong in nursing, you'll have a wonderful career. And it is challenging for some people. We actually have a float team here at CHEO with nurses that work in all the units because that's what they like. They like the variety, they like the change. And, they could work in emergency department one day, the next day they could work up on an inpatient medicine floor. They sometimes come and work in my NICU. But for a lot of nurses, you kind of find a place where you bond with your patients, you bond with the families. And for me, it was NICU. So I've been incredibly fortunate to take care of a lot of babies and a lot of families. Being a NICU nurse is really nursing the family. As much as you're nursing the baby, you have these two brand new parents who have a baby that's not well. When people are expecting a baby, they don't expect to come to a NICU and have a baby that's not well, right? You expect to have the perfect birth, and then you go home and you celebrate and you become a family, and life is wonderful. But when you have to stop at the NICU, it's a challenge, right? So Some of our kids can come for a week. Some kids stay for 4 months, 5 months. Some kids, they leave our NICU but have to go to the PICU because they age out of NICU. NICU babies generally, by 3 months of age, 4 months of age, you're starting to be more of a pediatric patient. So a lot of times at that point, we'll transfer our patients so that they have the benefit of getting the expertise of our pediatric intensive care unit because it's a little out of our wheelhouse. But what I would say is, it is an incredible opportunity to bond with families. If the babies stay for 3 or 4 months, you get to really know the families and their babies. Um, COVID was exceptionally hard on our families because only the parents could visit. So for the first time in my career, over the years of the pandemic, we couldn't allow grandparents in. We couldn't allow aunts, uncles, siblings. That was really hard because these families need a lot of support, especially our long stay patients. When they have a baby and they can't even get the support of their, a mom can't get the support from her mother or her father, you can imagine how difficult it is. So the NICU staff really become your family. And so, I think first and foremost for me, when I think of NICU nursing, I think of family nursing. And I always enjoyed primary nursing. So something that we do in our NICU is if we have those long stay patients, we try to find groups of nurses that will take care of them. Usually we'll get a group of people that work full-time and part-time so that we can kind of cover all the shifts. And then the baby and the family get to know a select group of people, and it kind of makes it a little bit more personalized for the family, and we get to know the baby so we can advocate for them a lot better, getting to know their needs and things that the babies like and don't like. And I think that kind of helps the parents as well because it makes it a little easier for them to go home at night when they know the nurse that's taking care of the baby. And they have create a bond with them and a trust. And I think for me, I would say over the years that's probably been the most rewarding part of my job. I love seeing the families come back and come to see us. And we had a little girl that came in today who was with us for better part of 2 or 3 months last fall, and came in to visit us today. And she's twice the weight she was when she came, and she's chubby and sweet. And they came in and we got to take pictures. And so, I mean, those are the rewards of your job, is to actually see a baby go home and really do well. And, you know, they may still have medical challenges when they go home, but they are living their best life at home with their parents. And it's really encouraging to see that. And I think that's a big rewarding part of our job as well, is to see these kids flourish and grow and do really well at home. So like they said in my bio, over the years, I've been a preceptor. So I spent the better part of 20 years precepting nursing students, new nurses to our unit. I've had midwife students. I've had more. I think we've had some RT students that have done little placements with us with nurses. They also do train with the RTs here in our unit. CHEO is a learning hospital, so pretty much most disciplines here at CHEO have learners with them. So for example, in my unit, the neonatologists are the neonatal intensive care specialists. We have fellows that are studying to be neonatologists. We have our residents that are going through CHEO doing their 4-year residency program. Our dietitians often have students. Our social worker has a student right now. Our NP has a student with her. So there's usually a lot of learning happening in the unit at all times, which is really nice because there's a lot of collaboration and a lot of sharing of information. One thing that I find really great here in our NICU is the interdisciplinary approach to caring for our babies. So every day we do rounds on our patients, and all of the disciplines that I was just mentioning to you, they all get together and we go around from patient to patient and we make plans for the day. So our nurses here are very valued in their position, and we have a very big voice, and usually we're the ones that will lead the rounds for our patients. And so, like I said, we have a dietitian, we have our own pharmacist, we have our own social worker, and then we have a team of physicians, so the fellows, neonatologists, residents, but they're not just rounds to plan the day, they do teaching on rounds as well. So in my 30 years, I have learned a heck of a lot just attending rounds and being part of rounds for my patients, which I find really nice. I put PICC lines in. It's something, we have a small group of nurses in our unit that insert PICC lines on these babies. It's an advanced skill. And one thing that all of the nurses in NICU do is we do all our own blood work and IVs. So there's lots of phlebotomy as well involved in our positions in the unit. And we have a staff of about 95 and 8 of us are trained to do PICCs. So we, on any given day, I can come in and an admission comes in and they might need a PICC line. We use PICC lines quite frequently now. They're pretty much a standard of care for any of our surgical babies. What makes our NICU actually different than the NICU over at the general is actually that we are the only ones that do surgery on infants. So we're a surgical NICU. So we're a level 3B. So we're the highest level of NICU care that you can get here in Ottawa. Our colleagues over at the Ottawa Hospital, the general campus, are level 3 as well, but they're a step below us just because they don't do the surgery. So even if a baby's born over at the general and they need surgery, even though they're in a level 3 there, they would be transferred over to our NICU to have surgery. We also have a transport team. So we're not an inborn unit, right? Because moms don't deliver here at CHEO. So we have a transport team that picks up babies. There are 3 transport teams across Ontario that can pick up neonates. So it's CHEO, Sick Kids, and London Children's. And so they break up the province into 3 parts, and our teams can go anywhere within our catchment area. Our transport team, for example, goes up to like Hearst, Moosonee, Cochrane, so we get a lot of families from Northern Ontario. We also have the contract with Nunavut, so we get the babies that come down from Nunavut. So any baby that's born up there that's premature or is sick when they're born or needs to have surgery would come down as well. So it's a very interesting unit because you get a good mix of the premature babies. We get all the babies that need to see specialists because the specialists at CHEO don't travel. So cardiac babies, genetics, lots of different types of illnesses, metabolics. We see genetics. We have a lot of specialists that come to our unit. So we see a pretty wide variety of different conditions in our babies. Just to give you a little idea of what my typical day is like, my position was created so that I could help and mentor all the new staff. So for example, in my unit in the last 3 years, we've hired 66 new nurses. And we actually, right now, are a staff of 93. So that's about 2/3 of our nurses that were replaced. I will say that probably a pretty good portion of those nurses actually left our unit for retirement. And they all had put in 30 to 40 years in the NICU here. So they spent their entire careers in our unit, and it just kind of coincided with this nursing shortage that they were all due to retire around this time. So on any given day, I staff around the needs of our new hires. So once they're hired and they've completed their mentorship with their buddy that we set them up with, and they're working on their own, that's kind of when I step in and I'm there as a resource for them. So they're never by themselves. We always have nurses there to help them. You get 12 buddy shifts and you get a good education at the Champlain Maternal Newborn Regional Program. They have a neonatal course, which consists of about 10 8-hour education days, and they get a good theory base in NICU nursing. But we actually even with all that, it's a big learning curve, right? So I'm here to mentor the nurses and to help them with anything that they need at the bedside. I know you guys were quite interested in sort of the research aspect of it. So our unit is part of EPIC-Q. So EPIC-Q is a group, is all the neonatal units across Canada. We all meet together. I actually just came from a conference out in Banff, and they do evidence-based research, which is phenomenal. So our site participates in some of the research that they're doing, and we actually just hired an advanced practice nurse in our unit, and she's going to be contributing to a lot of that research. So our unit does take part in a lot of research studies, and we hope to continue to participate and be part of the research that they're doing. And we do, so I will say one of the things I've noticed a lot over the years being a nurse over the long 30 years of my career is really the evidence-based practice research that's coming out. We've changed the way we do a lot of things based on research. So I'm quite pleased that our unit has had a lot of participation. One study I will briefly share with you that we did was sucrose. So we use sucrose, oral sucrose. It's just a bit of sugar water to help babies through painful procedures. And our NICU was part of that study here. And I have to say that in all my years here, it's probably one of the simplest and best things that we've come up with to help babies with procedural pain. So putting an IV in, for example, or doing blood work with a baby can be literally painless with a little bit of sugar water on a soother. And so we do participate in research. We do appreciate a lot of the research that's done because it really leads the way in our unit for providing good care to our families. I am also best practice spotlight nurse. So I'm part of the RNAO. So that's the Registered Nurses Association of Ontario. And it is also, they provide opportunities for nurses to do RNAO fellowships in different studies or research that they want to do. So we have 2 staff that have just gone through their fellowships, and they actually got to study about cooling our patients. So for our babies that have brain injuries at birth, we do full body cooling. So it's hypoxic ischemic encephalopathy that these babies suffer with when they've had a birth injury. And we actually will cool the babies. We do a therapeutic hypothermia. And so 2 of our nurses had the opportunity to do fellowships and go visit other sites in Canada that are championing the therapeutic hypothermia, and they're bringing those ideas and a lot of those things back to us. So the fellowships are amazing because they allow us to network with our colleagues, do research, and bring evidence-based practice to us. So I think I'll stop there because I think I've talked for a very long time. I'm very passionate about nursing and my job. So I'm happy to answer any questions that you guys have.
Okay, if anyone has any very quick questions, I think we have time for just one question. If not, we will move on just because we're running a tad bit behind. But thank you so much, Tina. Oh, we have a question. Did you want to go ahead?
Yeah, my question is about what other, apart from NICU nurses, what other nurses might you ever have the opportunity to collaborate with? Yeah, or
Oh,
yeah.
yep. So in the NICU, like I say, we're very multidisciplinary. So I actually collaborate with the other CRNs in the hospital. So we often will share knowledge. And so if there's babies that go up to say the inpatient medicine and they need some help, I can actually go up and help them and teach their nurses, if they're struggling with the care of one of our babies that's been transferred. But again, I mean, we have lots of opportunities. Last year when our PICU experienced the surge here, we collaborated with our PICU educators to come over and help teach our NICU staff how to take care of babies with RSV. So there's always opportunities for collaboration.
Thank you so much, Tina, and thank you for your questions. We'll just ask that you send them in the chat or ask one of us, and we will ask Tina later for you. I would like to introduce our next speaker, Dr. Hugh McMillan. He is a professor at the Department of Pediatrics, specifically Pediatric Neurology, in the Faculty of Medicine at the University of Ottawa. He joined the Department of Pediatrics at CHEO as a pediatric neurologist and a neuromuscular specialist in 2010. Dr. McMillan's training includes a medical degree at McMaster University in 2000, a pediatric residency at McMaster University in 2004, pediatric neurology residency at the University of Ottawa in 2008, and a neurophysiology fellowship in 2009 at Tufts University, and a neuromuscular fellowship in 2010 at Harvard University. Dr. McMillan is the program director of the Pediatric Neuromuscular and Electromyography Fellowship Training Program at the University of Ottawa. He has been an author or co-author in 130 publications in peer-reviewed journals. He was an editor of the Pediatric Electromyography textbook with over 25 international contributors. Since joining the University of Ottawa, Dr. McMillan has been a national leader in the area of clinical and translational research in pediatric neurology and neuromuscular medicine. He is a clinical investigator at the CHEO Research Institute. He was granted the CHEO RI Outstanding Investigator Award for 2018. He has been the principal investigator for over 20 industry or sponsor-initiated clinical trials and 2 investigator-initiated regulated clinical trials. Active and recent clinical trials include spinal muscular atrophy gene replacement therapies for Novartis SMART trial for symptomatic children with spinal muscular atrophy, as well as boys and young men with Duchenne muscular dystrophy, so gene replacement therapy, dissociative corticosteroid, and antisense oligonucleotide treatments. His area of study includes neuromuscular disease, rare disease, and spinal muscular atrophy. And I am happy to lend the floor to Hugh McMillan.
Well, thank you very much, Abigail, for that introduction. I thank all of you for giving me a chance to speak tonight. I really am pleased to be part of this. I was asked to talk a little bit about what brought me to CHEO and what sort of transpired for me to decide to practice in pediatrics and pediatric neurology. And I have to say, I'm very envious of Tina, who decided very early and who was sounds like, fresh off the mark to start a career at a relatively young age. It took me much longer for me to figure out, A, that I wanted to go into medicine, B, that I wanted to go into pediatrics and more specifically pediatric neurology. It wasn't until I was in my mid to late 30s that I actually started as a staff. And I think that in part was due to being part of a lot of different residency and fellowship training programs, which I loved, and helped me kind of discover what my real passions were along the way. It was really early in my training in medical school where I decided that I was really drawn to pediatric medicine and caring for children and youth and their parents. And there's a few different reasons for that. I think one of them is working with kids and their parents. There's a real need to have a level of empathy to really understand and reflect to them that we are understanding how difficult it is for them to be in the hospital or to be seeing us in clinic, and also a real need for us to be calm. And I think sometimes when we think about kids, people will think about being excited and being loud, and sometimes that works when someone might be in a camp or might be in a playground, but my experience is that when we're seeing a child in clinic, particularly younger children, pre-adolescents, it can be a really scary place for them. So to be empathetic, to be calm, to speak in a reassuring and in a soft voice really goes a long way to helping them feel more comfortable, for helping them to feel more at ease with this weird dynamic that they're in, meeting this doctor or this stranger that they've never met before. And it also really requires a lot of flexibility, which was something that I really liked because I remember as a medical student when we were learning to do an examination on adults, and we would really start like head to toe and look in the ears and look in the eyes and look in the mouth and kind of work our way down. That doesn't work with kids at all. Because some of the things which we would start with in an adult exam, like looking in the mouth, are some of the most invasive procedures or most invasive things that we can do for a child. So it's really about asking the question, what do we really need to assess in this clinical exam? And what do I need to assess while the child is calm and comfortable? And start with that and then move towards the other things a bit later in the exam. So having that flexibility as well. And then another really important thing, and I don't think this is unique to pediatrics, but it's really essential, is having good communication skills on top of the empathy. Because not only is it important to describe things in an age appropriate way for the child or for the young adult, it's also really important to explain things to parents and allow them to understand why they're what's going on with their child and what the plan is, even if we don't have a diagnosis yet. And I have to say, I think that's one of the things that is a big deciding factor as to whether people are drawn to pediatrics or not. I think the people that are drawn to pediatrics and succeed there are those that understand how difficult this is for the child, the young adult, and the parent, and those that struggle with it or say they don't like to work with the parents. Those are the ones that have difficulty with that. And it's really, in my opinion, about helping a parent who, prior to their child becoming ill, was making 100% of decisions about everything that happened in their life, from what they wore to what they eat, to what they do during the day, in the case of the youngest children, to now being in a situation where they still certainly have control, but not to the same extent. Someone's doing blood work, someone's putting in an IV, and that can be really overwhelming for a lot of parents. Some will react, with fear, being really overwhelmed. Some will react with being angry. But helping a parent understand what the plan is, helping them to understand what the path forward is, and engage with them and allow them to be actively part of the decision making can really help for them to gain back some of that control and to be able to be a more active participant in their infant or their child or their youth's care is really, really essential. Later in my training, when I was doing my pediatric residency in pediatric neurology, that's when I really personally became very interested in some of the rare and complex diseases that I'll talk a little bit later on when we talk about some of the research that I've been very fortunate to be part of. My day, I don't really have a typical day, which again is one of the things I really like about what I do. I run clinics, and I see myself as a clinician first and foremost, caring for people that have medical problems. I run a general neurology clinic, and that is medicine for children who have problems anywhere from their brains, could be seizures, could be migraines, could be a brain tumor, to spinal cord problems, to motor neuron, peripheral nerve, or muscle problems, and everything in between. Some of them are acquired, like a person that may have been in a car accident and has a brachial plexus injury, and some of them can be genetic or inherited. So some of the metabolic disorders or some of the muscular dystrophies that I care for children with. I run a neuromuscular clinic as well, and that's a multidisciplinary clinic where we try to provide a 360 care with all of the necessary subspecialists and generalists and all of the health professionals to allow the child and their family to have one-stop shopping. So if they have a muscle problem and they need to see a neurologist and a physiatrist and a respirologist and others, they can see them all in one visit if they want and let them get on with their lives afterwards, rather than coming back and forth again and again. I also will be very involved in neurophysiology, which is nerve conduction studies and EMG. Some of that I do on my own in clinic, and some of it I do with colleagues, for example, in plastic surgery. And I'll help to guide them around decision making that we will all make together, myself, the surgeon, and the family, about is a child's injury of a sufficient severity that it would be in the child's best interest to proceed with surgery now? Or, depending on what I'm finding on the neurophysiological testing, is there some evidence of connection between the nerve and the muscle? Is there the potential for recovery on the child's on their own? And if that's the case, then we don't want to do surgery. We would want to give them time to see if they're demonstrating the ability to heal themselves. So very interesting working with some of these super specialized surgical specialists to provide input that can help them to be able to make decisions around surgeries. And then in addition to the outpatients, I spend a lot of time in the emergency room on the hospital wards when I'm working on service as a consultant to do consults on children that are sicker and need to be admitted to hospital. I think the other piece that's really interesting about what I do is, in addition to providing a really detailed neurological exam and a clinical exam, which in my opinion is really the key at helping to decide and direct testing and to help with the diagnosis, I also really enjoy ordering imaging, particularly MRI or ultrasound that can help to guide us. Genetic testing to order and interpret those where available, again, to try to come up with a more precise diagnosis. And I'm also day to day very heavily involved in medical education. So we have a phenomenal residency training program in pediatric neurology. I encourage you to look into it. We take one Canadian trained medical school graduate every year to be part of our pediatric neurology training program. So we see those residents through a 5-year program. We also have off-service residents in pediatrics and in adult neurology and in physiatry that will rotate through our service as well to learn more about pediatric neurology and caring for children who have neurological disorders. And as Abigail mentioned, I'm also the program director of a fellowship training program in neuromuscular medicine and EMG. So really invested in medical education, which I really enjoy. And then another big part of what I do is clinical translational research. And really, there's a few different sides to that. One of the biggest sides is making emerging therapies available to children with neuromuscular and neurological diseases as well, who live in Ottawa, making it available to them. Because when I first started working in CHEO in 2010, we really didn't have access to clinical trials in Ottawa and really in Canada. And a lot of patients that had diseases like SMA, spinal muscular atrophy, or Duchenne muscular dystrophy, I would have to connect them with one of my colleagues in the United States and then send them down to the US to participate in these trials and have access to these emerging therapies. And I realized pretty quickly as a new staff, I said, this is unacceptable. We need to be able to be running these trials in Canada and in Ottawa to make these therapies available to children here. They shouldn't have to be traveling down to the US to be part of this. So it was a lot of conversations, a lot of partnerships, working with colleagues in the US and even across Canada for us to have clinical trial sites set up in Canada and for us to begin to be part of that. And I have to say, it's been a terrific success. And Canada's really contributed and been punching above its weight in terms of being part of some of these clinical trials. Ottawa in 2018 was the only Canadian site that was part of the gene replacement therapy trial for infants who had spinal muscular atrophy. And we were dosing children in the first 2 or 3 weeks of life. I think the first one was 10 days old, and just seeing quite incredible outcomes in terms of what these children would do. And just to hone in on SMA as an example, SMA is a disease that affects 1 out of every 10,000 children. It's now part of the newborn screening program. It's 1 out of 50 of us are carriers. And the more severe form that affects about 60% of children is really devastating. Children will, on average, only live without treatment to about 8.5 to 10 months of age. And most of these children will pass away because of complications of their weakness untreated before they turn 2. And being part of some of these trials, and in particular the gene replacement therapy, we were seeing these children sitting at a normal age, many of them standing and walking at a normal age or running, and just dramatically changing the natural history of this disease. And it really felt good as a neurologist to be part of something where, when I started my training, which wasn't that long ago in 2010, it might feel like a long time ago for you guys, but it doesn't seem that long for me, where there were no treatments, to getting to a point only 8 to 10 years later where we're able to offer these treatments that can literally change these children's and these families' lives. And we're part of similar trials with Duchenne muscular dystrophy that involve gene replacement therapies. Some of them also involve gene modifying therapies called ASOs, or antisense oligonucleotides, which are different novel treatments to help to improve dystrophin, improve their muscle strength. So really quite incredible treatments. I've also been part of what are called investigator-initiated studies. So those are ones where I will actually act as the sponsor and get approval from Health Canada and move them forward on my own accord. I've been part of research with other colleagues, and in some cases with medical students from the University of Ottawa, to look at medical education projects or quality assurance projects. One looked at confidence with lumbar punctures and strategies using using models like simulation is the word I'm looking for, to help reduce anxiety in people that are learning lumbar punctures in children. I also take being a mentor or a guide in research very seriously, and there's a lot of different medical students and residents that I've worked with that have been able to write up case reports of rare diseases or case series, or even retrospective chart reviews. So there's so many different areas that we can contribute to research to advance our knowledge and to make emerging therapies available for children. So I would really encourage you all to to really think about pediatrics, the wonderful difference that we can make at a young age that can change the trajectory of a child's life, to be able to work with their parents to empower them. And I'll maybe end just by saying something that I learned from one of my mentors when I was training. And my mentor said this in response to the whole sort of concept of, how depressing must it be to work with children that are sick? To which I completely disagree, and say, although I have no power over why a child has arrived in my clinic or has come to hospital, I have tremendous power in being able to deal with that child and interact with them in a sensitive and empathetic way, to help to empower their parents so that they have a path forward and a plan forward, and they're better equipped and better able to deal with the challenges associated either with their illness or with their hospitalization. So I'm going to stop there, and I'm happy for you guys to sort of take things in whatever direction you want.
Great. Thank you so much, Dr. McMillan. I will just ask for maybe one quick question, because we are running a bit tight on time and I'm sensitive to everyone's time. So if anyone has any quick questions, you can either raise your hand or put it in the chat. I have one sent to me in the chat. They're asking if you have any open research undergraduate student opportunities this summer.
This summer we've filled up. We do have students that are coming with us this summer. If there are students that are interested in being part of research, who are interested in pediatrics or pediatric neurology, I'll put my email in the chat, and you can always reach out to me privately, and I'd be happy to talk about that. I'd be happy to talk even about next summer if that potentially works out, which would give us a bit more time.
Perfect, thank you. And just one more in the chat. Matthew's asking if there are any key differences in adult versus pediatric electrophysiology.
The premises are very similar. So the technique of nerve conductions and EMG are very similar between children and adults. The normal values are different, because as children's nerves are myelinating and as they're growing in size, we see measurable changes in things like conduction velocities. So it has to be interpreted in the context of the child, particularly when they're young. There's also a need for us to select muscles that are more appropriate to study, to try to reduce the number of tests done in children, acknowledging that it is a bit of an uncomfortable study, particularly the second part, to gauge whether or not sedation may be required in select cases. So in general, similar principles, but there's select age-appropriate considerations that we always have to keep in mind.
Great, thank you so much, Dr. McMillan. We'll now be transitioning to our third part of the event. We'll be doing our tutor awards now. So I just wanted to thank all the speakers for coming out tonight. We couldn't run this event without you, so thank you so much. I'm just gonna start sharing my screen so that you guys can see our tutor awards. Can everyone see my screen okay? Okay. You guys see the screen? Okay. Okay, so our top 10 tutors who dedicate the most hours for this year are as follows: Omar, Aya, Wojciech, Gabriela, Joseph, Manasvi, Toshka, Julie, Aisha, Brenna, and Daniel. And we also wanted to do a special shout out to our exceptional midterm prep session tutors, who are Daniel, Azana, and Kevin. And so all of your awards, your award certificates will be reaching you by the end of the academic year. And I just want to thank you guys on behalf of the entire LFC team for dedicating, all your valuable time on top of your own course loads, and your commitment to our club's endeavors they're always very much valued, and we couldn't have done it without you. So now I want to move on to the moment that everyone's been waiting for, the check presentation. So this is how much we've raised towards CHEO for the academic school year of 2023, so the fall of 2023 and the winter of 2024 so far. So I'm not going to ask for a drum roll because we're all online, but on the next slide, it has a grand total. So far, as of last night, we've raised a grand total of roughly 10K. Yay! Great job, everyone. So we still have tutor sessions that are continuing till the end of April, I believe, with our exams. And then we also have another final prep session planned for a few courses. So with that, we will definitely be surpassing 10K for sure. So this will all be donated to CHEO, as you guys are aware. And with this, I will stop sharing my screen and pass it over to Steve Reed, who is the president and CEO of the CHEO Foundation.
Oh, that's just an outstanding result, everyone. Thank you so much. That's really amazing, and I guess maybe first of all, I just want to thank you for the invitation to join you this evening, and congratulations on putting on such a great program. It's really nice to be part of a celebration like this. I'm very grateful for the opportunity to hear about all the great things that you're doing. When you talk about the work that you're doing, there's an awful lot for a guy like me to be impressed with. I mean, just the fact that you're all students at the top of your class. I mean, that's reason enough to be impressed, but then add the tutoring to your busy days so that you can help others achieve their goals, and then turn that into fundraising activity that supports all the kids and families that come through our doors at CHEO. That's just incredibly admirable. And I hope you're all very, very proud of the contributions that you're making. In my role, I have the privilege of working with many, many individuals and companies and community groups who have made the choice to support child health in our region. And we see annual giving and monthly giving and corporate philanthropy and hundreds of groups who host, community fundraisers and golf tournaments and so on. But I don't think I've ever come across a more innovative and successful fundraiser as the Learning for Charity program. So you guys are really embodying the spirit of charitable giving and using your talents and your resources to provide the kind of support to all of us, or those like Adam and Tina and Dr. McMillan, who've devoted their whole careers to child health. So thank you very much on everyone's behalf. CHEO was built 50 years ago when the whole community got together and lobbied the government to build a children's hospital. And although an awful lot has changed in those 50 years, CHEO is still very much a community asset, and it's still supported heavily by the community's generosity. So when we raise funds through events like Learning for Charity, I mean, this is what allows us to put, the best equipment in the hands of the clinicians, the best programs in place to support the kids and their families that are coming to CHEO. And it also, as you heard, fuels the groundbreaking research that's now leading to new treatments and new diagnoses for kids, not just here in Ottawa, but around the world. So It's allowing us to grow our staff, to grow our programs and our physical space to address the growing demand, like you heard Adam talk about as well. So I hope you're incredibly proud of what you've accomplished with Learning for Charity. These funds are going to have a direct impact on patient outcomes. And at the end of the day, we all want the kids that we treat to live their very best lives. So on behalf of all of us at CHEO Foundation and our colleagues at CHEO and Research Institute and Roger Nielsen House, but especially on behalf of the kids and the families who are relying on us for care, thank you. Thank you, Armida, Akia, Caroline, Abigail, Rake, all of you who are involved in this great event. And thanks again for the invitation. I'd be happy to answer any questions if you have, but my main message is just to say thank you to all of you for such great work.
Great. Thank you so much, everyone. Oh, Danny has a question for you. Where does most of the money go towards?
Where does most money? Well, that varies. It's a hard question for me to answer because needs vary from one year to the next and from one time in a year to the next. But what this does is it allows me to sit down with my counterparts at CHEO or the Research Institute or Roger Nielsen House, who we also support, and ask them what's the biggest priorities for them. So one of the nice things about support like this that's coming from you is we can change directions and we can say, what's the most important next thing for us to acquire? Is it more support? Is it more equipment? Is it some more staff support? Is it some better space? So I'm never the one to make that decision. I always just, on behalf of the community and people like you that are helping support CHEO, I can go to them and say, where do you need this money the most? So that's why I'm able to say, this is having a big impact directly because it is automatically going to the things that matter the most.
Great. Thanks, everyone. If there are no more questions, I just want to thank you guys again, the speakers, the attendees, everyone, just for coming out tonight. It's late on a Tuesday night. I'm sure everyone has other things to be doing, but we really appreciate your time and efforts throughout the entire year, and best of luck with exams. You guys got this.
Thank you, everybody.
Have a great night, everyone.
Bye-bye.